I'm Helen Ajufo. I am a second-year fellow at Memorial Sloan Kettering Cancer Center. So I am here to discuss a little bit about splenic volume reduction and overall survival in myelofibrosis patients on pacritinib, but not best available therapy, the PERSIST-2 overall survival analysis. So looking at the PERSIST-2 study, we assess the relationship between splenic volume reduction and survival in patients with cytopenic myelofibrosis treated with pacritinib 200 milligrams twice daily versus best available therapy. Pacritinib is a JAK2 IRAK1 ACVR inhibitor. Looking at the survival curves, so these were stratified by splenic volume reduction greater than or equal to 10%, greater than or equal to 20%, and greater than or equal to 35%. And in patients with thrombocytopenic and MAP defined as a platelet count of less than 100, we see an overall survival benefit or association with overall survival increased in patients who had greater than or equal to 10% splenic volume reduction, 20%, and in the 35 or greater percent splenic volume reduction, there was a significant increase in overall survival. The greatest separation of the curves was seen with the greater than or equal to 10% splenic volume reduction in overall survival in patients with thrombocytopenic MF who received pacritinib. Looking at the best available therapy arm, so in the best available therapy arm, no tested splenic volume threshold was associated with survival. The overwhelming majority of patients treated with best available therapy in the PERSIST-2 study received ruxolitinib, and although most of the patients received a dose of less than or equal to 10 milligrams twice daily, we did see greater than 35% splenic volume reduction in patients, or significant splenic volume reduction. We just didn't see an association with overall survival. So what's interesting is that in previous studies of ruxolitinib, we've seen that even in patients with 10% splenic volume reduction, that there is an overall survival benefit in patients who have platelet counts of greater than 100,000, even patients typically enrolled in trials. And then with greater than or equal to 35 splenic volume reduction, there is more marked improvement in survival. So this has been the sort of accepted endpoint for most of the drug trials for myelofibrosis. What's unclear, though, is the optimal cutoff for survival for splenic volume reduction and overall survival in the cytopenic patient population. And we know that cytopenic MF is a different profile to non-cytopenic MF, and that patients tend to have co-occurrence of both anemia and thrombocytopenia. They tend to have more somatic mutations, they tend to have more aggressive disease, and just overall poorer survival compared to non-cytopenic MF. In addition to more transfusion dependence. So both anemia and thrombocytopenia in and of themselves are associated with overall survival. So taking all of that into consideration, pacritinib, what we may be seeing here is that working through IRAK and ACVR, we're seeing improvements in the anemia profile and the thrombocytopenia profile, as well as the anti-inflammatory benefits that we may not be seeing with ruxolitinib, which are providing an overall survival benefit in this patient population. Additionally, that less reduction in spleen size, although we're seeing that there is less reduction in spleen size, we're seeing improvement in other parameters that may be viable surrogate markers for disease control or for response. And so I guess the takeaway point is that pacritinib may have other disease-modifying benefits that we're seeing here that confer overall survival advantage or benefit, and that looking at future lines of therapy, then in the cytopenic MF population, their anemia, thrombocytopenia and other sort of anti-inflammatory pathways may also be viable surrogates to look at disease control in response to therapy outside of splenic volume reduction.